Good afternoon and good morning to those of you in Mountain and Western and beyond time zones. We welcome everyone to the Creative Nursing launch event hosted by the Future of Nursing Campaign for Action, an initiative of AARP Foundation, AARP, and the Robert Wood Johnson Foundation. The campaign is coordinated through the AARP Center for Health Equity Through Nursing. I'm Winifred Quinn, the Director of Advocacy and Consumer Affairs for the center. Before we begin the event, we would like to acknowledge the land in which we sit. And in fact, Jasmine and I are sitting in AARP's New York City office. Over 3 decades ago, President George H.W. Bush designated November as National American Indian Heritage Month. Since then, during November, Americans across the nation proudly honor and recognize the invaluable contributions and accomplishments of United States Indigenous peoples that have shaped our country and celebrate the contributions and vast cultures of the United States' 574 federally recognized tribal nations and the over 1,000 tribal nations that existed prior to colonialism. AARP celebrates the invaluable contributions, accomplishments, and culture of our Indigenous people year-round in our mission, vision, and purpose, and through the meaningful organizational and community work we do. AARP invites us all to explore and honor the rich original stewards of all of our local community lands. Speaking to you from the AARP New York City office today, we acknowledge and honor the land on which we stand and sit here, and connect with the lands along the Hudson and East Rivers. This land is where the following tribes thrived: Iroquois, Oneida, Lenape, Cayuga, Seneca, Onondaga, Mohawk, Tuscarora, and Shinnecock. Nearly 200,000 people in New York City identify as American Indian or Alaska Native. We honor them, their ancestors, and all Indigenous people who came before us on this land. Thank you for the opportunity to provide this land acknowledgement. I would like to give a brief history of the Future of Nursing Campaign for Action. The campaign was launched to implement recommendations from the then Institute of Medicine's 2010 report, Future of Nursing, Leading Change, Advancing Health, which focused on building a robust nursing profession responsive to the 21st century needs. All of our work is housed within the AARP Center for Health Equity Through Nursing. The center was founded to align nurse leadership and consumer voices to end structural barriers to health and well-being. It serves as a vehicle for change, hosting specific programs and activities that align with AARP's health equity priorities. If you would like to learn more, please visit our website, campaignforaction.org. We would like to thank Sage Journal for the opportunity to serve as the organization host for this event. I'm now delighted to turn it over to Marty Lewis Hunsteiger, co-editor-in-chief of Creative Nursing.
Oh, thank you. And either Hunsteiger or Hunsteiger is just perfect. And I would like to say, up until about 2 months ago, I was co-editor-in-chief of Creative Nursing. I am now editor, and our official editor-in-chief of Creative Nursing is Ahtasham Yunus, who's here today. So thank you, Dr. Quinn. We're so grateful for the support of the Future of Nursing Campaign for Action in hosting this wonderful event. I love these events. I just can't tell you. I'm joining you from Minneapolis, Minnesota, and the Mississippi River is right outside my window. It's a block away. And I'm grateful to live within the traditional and legal home of the Dakota people and a land over which the Anishinaabe people and others also moved. They gathered and ate food, rested, died, and gave birth, and prayed here, and many still do. I'm committed to honoring their ongoing legal, cultural, and spiritual connections to this land that I am blessed to live on. So on behalf of the editorial board of Creative Nursing, a journal of values, issues, experience, and collaboration, that's our formal name. I welcome you to this celebration of the publication of Creative Nursing, Volume 29, Issue 4. Volume 29, 2023 has been quite a tumultuous year, and we're so glad that we have this final issue to celebrate. We have a growing community of scholars, they're thought leaders who are willing to write about and talk about challenging issues. We tend to publish articles that not all journals will even touch with a 10-foot pole. It's so exciting for me to see the authors of this journal who've published with us before, including Bridget Carter, Vernell DeWitty, Catherine Holton, Nina McCune, Susan Hune, and Sigrid Ladors. The theme of this issue of Creative Nursing is understanding the human and financial costs of marginalization. Our journal's 2023 focus, our overarching theme, was redesigning healthcare. And we highlighted the structures that support the healthcare workforce. That was issue 1. And issue 2 called into question the continued relevance of the legacy structures and habits of thought through which we encounter those we serve. Issue 3 looked at those structures in more detail, building on our journal's previous contributions to this knowledge. We've had 2 theme issues specifically about social determinants of health. And these articles that we've published in the past, they challenged all of our readers to recognize the potential embedded in every system and structure described for disparities in the provision of care. So my editorial for this issue was called Life on the Margins. In this final issue for the year, we discussed marginalization and what it costs us all. In fact, our media review for this issue, which will be discussed a little later by Lucretia Bell, is of the book by Heather McGhee. The name of the book is The Sum of Us: What Racism Costs Everyone and How We Can Prosper Together. In these articles in this issue, marginalization and the experiences of people who live on those margins are regarded, examined, explained, and analyzed. The articles this time are strongly oriented toward the US. Our journal is international, and many of our articles come from all over the world. This particular issue, it happens that our articles are from the US, but the concepts that we talk about are universal. So the things to look for, these concepts, there are synonyms for marginalization and terms that are related to marginalization: othering, stigma, minority stress, stereotyping, microaggressions, bias, conscious and unconscious, intersectionality, social determinants of health. And there are antidotes to marginalization: belonging, diversity, inclusion, sustainable partnerships, equity-minded nurses. These are terms that you're going to find in these articles. Service learning, culturally safe support, and ideas and questions to consider. Marginalization precedes or is the precursor to exclusion. The first step in excluding people is to marginalize them. There are levels and degrees of marginalization. There are different types and different manifestations of marginalization. Stigma is social rejection that comes from an imbalance of power and a lack of knowledge that excludes people from normed privileges or normed advantages. Intersectionality may increase marginalization. If you're a member of one marginalized group and also another, that the effect is sometimes exponential. What is the role of unconscious bias in marginalization? Who decides who gets to feel marginalized? Sometimes that message is there. You aren't allowed to feel marginalized. And belonging is the other end of the spectrum from marginalization. Several of the articles highlight the importance of diversifying the nursing student population, thus diversifying the nursing workforce. Strategies about this include strengthening support for historically Black colleges and universities. You're going to hear them mentioned several times, and the potential partnerships that they represent. Another is incorporating social determinants of health throughout nursing curricula to attract students from minoritized groups, and introducing potential healthcare professionals from underrepresented communities to career possibilities while they're still in high school making those decisions. Sometimes that's the best time to get their attention. For people who are already nursing students, we want to keep them in school. Intentional mentoring that addresses their need for representation and culturally safe environments can nurture inclusion, connectedness, strength, and thrivance. I love that word, thrivance. For students from majority groups, using simulation to depict structural racism in healthcare head on. There's quite a dramatic article about that. And offering opportunities for immersive service learning in underserved communities are ways to help them, majority students, understand and address unconscious bias that can lead to othering. Equitable attention to the specific healthcare needs of members of a group that is seen as the rarest of the rare, specifically African American people with cystic fibrosis, and those of sexual and gender diverse individuals is the essence of inclusion. So after all the articles have been presented, we'll have a moderated open discussion with an opportunity for questions and comments for individual authors and about the theme of this issue. We also encourage you to reach out to the authors personally. We'll be posting the list of the corresponding authors' emails in the chat. And they also, when you read the articles themselves, those contact addresses are at the end of each article. There's also an annotated table of contents that we generate each time that briefly describes each article. That document and then the recording of this launch event after post-production when we've cut out all the parts at the beginning where we were getting our stories straight. All of those will be posted. They'll be found on our new website of our journal. And our journal also has a Facebook and a Twitter page. They'll be posted there, and also on the link that Jasmine has explained about from the I'm sorry, the campaign for action. Pardon me. We'll post all those links in the chat, so please watch for them. And if you don't see them before, we'll post them again at the end. I'd now like to introduce Dr. Vernell DeWitty and thank her for her leadership in the role as co-guest editor of this issue of our journal. Vernell is going to first present her editorial, and then we'll introduce all of the other authors.
Thank you so very much, Marty. And I would like to extend my appreciation to both you and Bridget for this learning experience as a guest editor. It was the first time for me. And I would like to just remind the audience that if you have questions, please free to drop them into the chat box. And when we are done, we will move forward with the discussion at the end. So hopefully you'll be around for that. I would also like to thank the Center, the Campaign for Action, the Center to Champion Nursing, for hosting this event on behalf of Sage Publication and Creative Nursing Journal. The article that I co-authored along with Dr. Deborah Stamps and Jasmine Cooper was about having to do with a mentoring initiative for students at historically Black colleges and universities. And this is one strategy for increasing nursing workforce diversity and advancing health equity. The National Center for Statistics, Education Statistics, define HBCUs, and I'll give this to you because a couple of the other manuscripts do reference HBCUs. They are academic institutions that were founded before 1964 with the main mission of educating African American students. The Higher Education Act of 2008 required all HBCUs to enroll at least 40% African American students, 50% from low income or first generation students. Now, HBCUs also include and enroll other students from other racial and ethnic minority groups. In 2021, there were approximately 99 HBCUs throughout the United States, the District of Columbia, and the Virgin Islands. And of these 99 schools, 32 offered nursing programs, BSN nursing programs, 13 offered master level programs, and 5 offered Doctor of Nursing practice. 3 offered PhD program. And while They might represent a small percentage of all BSN granting institutions in nursing. They represent a significant role in increasing the diversity of the nursing workforce. In 2017, their graduates represented 6.7% of the total BSN degree graduates in the United States. Now, of course, some of the challenges of HBCUs are similar to other schools of nursing, such as support systems for academic success, the need for mentoring, difficulty with recruiting faculty, and retaining faculty. And in order to address these issues, schools of nursing must be intentional. One researcher reported that the attrition rate at HBCUs was about 27%. And what we know is that attrition increases the economic cost and reduces lifetime earnings of students who may become nurses. And now I will turn over to Jasmine, who will talk about what this unique, innovative, collaborative program is all about.
Thank you, Dr. DeWitty. So my name is Jasmine Cooper, and I'm the Senior Advisor at AARP's Center for Health Equity Through Nursing. And as Wynn mentioned during her opening remarks, the Campaign for Action is guided by 2 reports. And the recommendations from these reports is kind of where we got started with our mentoring initiative and our goal to increase retention, graduation rates, and NCLEX passage rates for students from historically marginalized backgrounds. We began our work with a pilot program convening 8 Mid-Atlantic historically Black colleges and universities with a traditional BSN program. Following that pilot, we established a series of 2-day mentoring training workshops. The first workshop was held at the White House Initiative on HBCU's 2019 National HBCU Week Conference, where 23 HBCUs participated in the conference's first ever nursing track. The series continued with trainings offered to Hispanic serving and American Indian Alaska Native serving schools of nursing. Following those series of workshops, we established a mentoring learning collaborative for each audience and a joint learning collaborative that brought all 3 sets of schools together. Through these monthly engagements, 3 themes of support were identified: the need for NCLEX preparation, funding support, and mentor recruitment. With these 3 themes in mind, we expanded the program by offering a NCLEX Train the Trainer workshop in co-sponsorship with NCSBN to train 11 faculty to provide pro bono trainings on the next gen NCLEX. We also established a relationship with HRSA's Division of Nursing and Public Health to keep nursing schools better informed about funding opportunities and to provide technical assistance with the grant writing process. The last thing we did was we developed a strategy to recruit nurse mentors for the schools of nursing we work with by collaborating with AARP's Office of Volunteer Engagement to create a nurse mentor volunteer position. This collaborative effort provided the campaign with access to over 500,000 AARP members who are active or retired nurses. Once a nurse does sign up and volunteer for this role, they're given access to a portal that offers additional training and webinars on how to be a mentor. They're also asked to complete an extensive mentor survey that obtains information about their career, expertise, mentoring experience, and organizational affiliations. And then once a mentor completes all of the courses in the application, their application is then sent to the schools that they selected for them to then identify the matching criteria and mentoring requirements for their program. So as of today, I'm happy to say that we have recruited over 100 nurse volunteers, and we're excited to recruit more. So thank you so much for your time. I'm going to hand it over to Dr. Deborah Stamps to continue to talk about our article.
Thank you so much, Jasmine. My name is Deb Stamps. I am the CEO and founder of Deborah Stamps Consulting and had the pleasure of collaborating on this article with Jasmine and Dr. DeWitty. So I'm going to share with you some program evaluation. Participating schools were requested to participate in a survey regarding their program implementation, barriers, and additional support needed for implementation. The most common stage of readiness was identified as contemplation, with 60% of the respondents identifying contemplation, followed by initiation, 30%, and growth maintenance of 10%. All participants identified at least one form of needed assistance to enhance or establish their mentoring program. There were three common needs. One of the first ones, which is the largest need, was funding, followed by mentors. And then the need for NCLEX preparation. The availability of mentors was the least identified need at 30%. Most of the participants reported feeling excited about enhancing or implementing a mentoring program, whereas a minority felt overwhelmed at 30%, 20% felt ready, and 10% were curious, and 10% also felt discouraged as well as unsupported. Most of the HBCUs, 80%, reported being interested in participating in the Nurse Mentor Recruitment Pilot Program. However, most of them, 60%, reported that their schools needed more time to be ready to accept new mentors and mentees. When we look at, next slide, please. When we look at the conclusion and recommendations, we know that a diverse nursing workforce is imperative for today's diverse patient population. Mentoring is a given success strategy for nurse retention and provides nursing students with reassurance, guidance, and motivation. There are three recommendations that were clear to us. Number one, that we have to encourage nursing schools that serve populations of students who have been historically marginalized to develop robust mentoring programs that provide a mentor to each student. The second recommendation is that we must develop programs that prepare mentors who understand the components of the mentoring process while considering their experience and background. And the last recommendation is that further research should explore the impact of mentoring on students in HBCUs. Thank you so much for the opportunity to share with you our article today, and I will turn this back over to Dr. DeWitty.
Thank you so very much for sharing the conclusions and recommendations, Dr. Stamps. And now we're going to move on to our next presenter, who's Dr. Deborah Barksdale, who will present on her article on the human and financial cost of health inequities. And we're going to ask our authors to please try and keep your summaries to 5 minutes so that we have enough time to cover everyone. Thank you so very much.
Thank you, Dr. DeWitty. Can you hear me okay?
Hear you just fine. Thank you.
I timed myself and was 5 minutes and 30 seconds.
Okay.
So I'm Deborah Barksdale again. I'm Dean and Professor at the University of North Carolina, Greensboro, and I'm happy to present on behalf of my other co-authors, Dr. Kapiri Ackerman Barger, we call her Piri, and Jessa Drayton-Murray. And they were not able to be with us today, and I'm going to have to leave shortly after this. We were asked by Dr. DeWitty to address the academic side. So we decided to do a call to action, and it's entitled Call to Action, Academic Nursing's Role in Redesigning Healthcare to Reduce the Human and Financial Costs of Health Equity. We know that health equity can only be achieved when systematic inequities are addressed. And what does that human cost include? It includes things like years lost, lives lost, quality of life, medical mistrust, financial loss. So the impact of continued health disparities in the U.S. is great. You all know this. You probably all wrote about it in your individual manuscripts. We also believe that increasing diversity in the nursing workforce is essential. And you've heard about some of the work that has been done by Dr. DeWitty and Dr. Stamp and Jasmine and regarding that. But we tried to focus on what it means to be an equity-minded nurse, and how we as academicians need to ensure that we are graduating equity-minded nurses. And we also discussed some of the innovations to address health disparities in terms of clinical opportunities. I really like this quote, and I have to read it to you. A nation cannot fully thrive until everyone, no matter who they are, where they live, or how much money they make can live the healthiest possible life, and helping people live their healthiest life possible is and always has been the essential role of nurses. Nurses then have a critical role to play in achieving the goal of health equity. And that was National Academies of Science, Engineering, and Medicine. So in our call to action, we address an increase in diversity to increase health equity from the academic point of view. So what that means is looking at the diversity in our clinical practice, our clinical placements, our clinical sites, our clinical opportunities, but also increasing diversity in the nursing workforce, not just in terms of the number of underrepresented minorities, for example, but in making sure that that leadership is diverse as well. And I think I see things getting better. I see promise, but we need to continually be working to assure that there are diverse voices at all levels of our academic institutions that are included in the decisions when resource allocations are made. Graduating equity-minded nurses, well, what does that really mean? So what it doesn't mean is just, for example, giving nursing students a taste of what social determinants are, social determinants of health. So it's just a nice, cute thing. But graduating nurses who see at their core the values related to health equity and advocacy and promoting and doing whatever we need to do to promote health and healthcare and health equity in all people. Piri and I had a discussion about this integrated curriculum, what it means and what it doesn't mean. I bet if we ask most academicians, do you include, say, social determinants of health in your curriculum? Everybody's going to say yes. Some will take the perspective of having an individual course, and then some will say, well, it's in all of our courses. And sometimes that becomes everywhere, but nowhere. And so we sort of advocate both models, having something that's dedicated toward helping students understand health disparities, health equity, social determinants of health, but also embedding it systematically and intentionally in every course in such a way that it provides context. And that will help too toward providing that graduating that equity-minded nurse. In our paper, we also discussed several models of care. I heard that beep, I'm almost done. We discussed several models of care that can be introduced to help address some of the inequities in healthcare. We focus quite a bit on mobile health units, and one reason is we have one, and they have one at Piri School as well, and how we can use mobile health to reach underserved populations, provide clinical experiences for students in which they might not otherwise get, and contribute to improving healthcare through educating and graduating equity-minded nurses. And that is the end.
Thank you so very much, Dr. Barksdale, for that informative summary. And we can hardly wait to read your article and move on some of the recommendations that you're making. And now I would like to introduce Dr. Regina Eddy, who is going to speak on mitigating Native American marginalization. Dr. Eddy, take it away.
Okay, good morning. My name is Regina Eddy. I'm associate professor in Arizona, Northern Arizona University, but I'm actually going to have our primary author, Dr. Michelle Khanjan, is going to do our presentation for our team today. So, Michelle, you want to go ahead and also do an introduction? Thank you.
Hello. Hi, everyone. Can you see the screen?
Yes, we've got you. Yes.
Great. Thank you. Okay, I am going to start my timer here. So Yat A, I, along with Dr. Regina Eddy, who you just met, and our student, Anna Slavin, who's a student at the Johns Hopkins University, are happy to present this work with you today. And thank you for the invitation. So we're going to discuss culturally safe mentoring for American Indian students, nursing students. So just to kind of go over some of the implications for this work, we recognize, both Regina and I are Native American, we're Navajo, we're members and citizens of the Navajo Nation, and we kind of reflected on our journey moving through the work of this article. And we recognize that there are often lots of strategies and resources in place to support Native American students. However, sometimes they might be culturally misaligned and sometimes even culturally unsafe, and offered without really truly understanding how to be helpful to Native students. And so we are going to share an intergenerational model that we've drawn from some of the traditional wisdom of American Indian elders and the ways in which they transfer knowledge to share with you all in this article today. So you'll hear a lot about the Native American worldview. You'll hear language like reciprocity and respect, some of the characteristics and attributes of nursing schools, nursing faculty, and mentors that we are emphasizing are critical factors for success in our American Indian students. So American Indian students are probably the smallest cohort of students, nursing students in the nation, at a rate of about 0.5%. In the article, we present a case with Samantha, just showcasing some of the differences that she may experience when she's engaged in nursing school. So for example, the cultural differences she comes with, the historical and intergenerational impacts of colonization that both she and her family may have experienced. And she brings that into the academic setting, and we as faculty need to recognize how that impacts her success or the difficulties that she may experience. And then we speak to the issues of racism and discrimination, marginalization, invisibility, and those psychosocial inequities that our Native communities have experienced historically and continue to experience today. And those things become risk factors for our students, and they have the potential to hinder their success. So when we think about cultural safety, these experiences, as I mentioned with the case of Samantha, the loneliness, the displacement, the invisibility, the discrimination, call for this need to really move forward with creating culturally safe spaces. And you've heard this in the two presentations already. We need diverse faculty. We need culturally informed faculty and staff, people who are very aware and know about the culture and know about the nuances of interacting and communicating and supporting in a culturally safe way. And then as nurses, we should know about compassionate, caring approaches, but sometimes we're so busy and our workload is so heavy that we forget to bring across that essence of compassion and caring in the work and the mentoring that we do. So we need the capacity for our mentors to deliver these culturally aligned mentoring strategies. So these are ways in which we can create these safe spaces. So we present this intergenerational mentoring in our communities and Native communities. Even though we have 500 plus Native communities recognized in the United States, they share this thread of the value of the wisdom keepers. So we kind of mirrored that with the value of us as nurses, as clinicians, as teachers, as instructors. We are wisdom keepers, and we are entrusted to transfer this information to our younger generations of nurses. And so with that, they have to trust us. There has to be mutual respect. There has to be equal power in these relationships of learning exchange, teaching and learning from one another. So we share that model here as a model that maybe we could try to remember and apply in our mentoring and teaching roles. So some of the attributes of culturally safe mentoring environments are the emphasis on student strengths and protective factors. For Native students, culture is protective. So creating spaces that are inclusive, that acknowledge the culture, that encourage students to draw on their strengths from their community, such as stories and language and art and ceremony, are ways in which we can help them to recognize those protective factors that will help them to be successful. And then remaining solution and goal oriented with their academic journey. Sometimes we focus on some of the deficits that students may have. Trustworthiness, compassion, mentoring capacity. Sometimes, as I mentioned, we're very busy. We don't have time to offer and be in this caring and compassionate way, but we need to create that dedicated time and space. We acknowledge a few exemplars of some of the programs that are offering culturally safe spaces. So we share that in the article as well. But we really emphasize the need to really bring these concepts and these ways of transferring knowledge in our schools of nursing to transform nursing education. And take seriously our responsibility as educators and as clinicians to share and transfer this knowledge and to diversify the nursing workforce. And so those are the key takeaways. I thank you. My buzzer went off, so I think our 5 minutes are up. I'm going to hand over to Regina, Dr. Eddy, to see if she has anything else to add. Thank you.
Actually, I think you covered it well. So since we'll stay within our 5-minute time. So, but I will add really quick, the table really highlights, we wanted to, with few programs that are available in the literature, but there are success programs out there. So please look at the different resources that we highlight in our manuscript.
Thank you both so very much, Regina and Michelle, for sharing this outstanding manuscript with us, and look forward to reading and learning more. You give us some words, wisdom keepers, compassionate, caring, and asset. Now we're going to move to Dr. Jennifer Jones, who will speak to us and highlight the student voice in service learning. Go right ahead, Dr. Jones.
Okay, thank you very much. Can you see my screen okay?
Absolutely.
Okay, perfect. So I'm sharing this on behalf of myself, Dr. Newberry, Dr. Spies, and I would like to point out that Dr. Yvonne Perez was a student who participated on this trip, who we invited to collaborate on the publication as well. So the background, this is based on a retrospective review of our trip, where we took a group of nursing students from Dallas, Texas to the Rio Grande Valley, the Mexico-Texas border, to serve in a COVID-19 vaccination clinic and also serve in a refugee respite center. This is the refugee respite center is the first stop after the ICE detention center. So that's where they come to clean up, get clothes, get some rest before they travel on to their next destination. So we were fortunate to be able to take this trip because of requirements due to COVID. So we had to have an academic component of it. So that's where the course that we developed for the students came into play. But the team consisted of myself. There were 2 faculty, myself and Dr. Newberry, both DNP prepared. We had 4 graduate students and 4 undergraduate students, which was an excellent pairing. It just allowed for interesting collaborations for one student to learn from another, share experiences that they wouldn't get from professors. So it was just a great learning experience for all involved. So we did develop a preparation, was the refugee and immigrant population health course, where they just learned about key issues related to immigrants and refugees, the differences and asylum seekers, and all of the different reasons that people may seek access to the United States through the Mexico border. And then we also did training on the vaccinations, because that's when the COVID vaccinations were new. So we had to ensure safety with that. So for this article, we did a competency-based evaluation looking at the essentials, which we all in academia are familiar with the essentials now. So we looked at how service learning could be used to accomplish the essentials. And our focus was on the social determinants of health. So to accomplish this, we had the students write essays on their experience, and we had asked them to focus on the health needs of the immigrants and the refugees, what health disparities they noted, how they felt about cultural humility before, during, and after the trip, and how this would impact their future practice. So the framework we learned from the students that many of them did actually live in the Rio Grande Valley, but did not understand the experiences of the folks coming across the border and how that impacted their care. And they just had no idea, even working locally. So it helped us evaluate that we could use service learning outside of the traditional didactic and clinical experiences to accomplish these competencies. So we'll use this framework to keep in mind as we form our future trips. So this is how we paired the essentials that were found. These were the common themes found in the student essays: clinical judgment, how they recognize the scarcity of resources and awareness of skills and the scope limitations, language barriers, obviously for communication, compassionate care. They have the desire to serve others, but how can we be advocates, use our nursing experience to be advocates for those who are less fortunate than us, or who are marginalized and don't experience healthcare the same way we do. Diversity, equity, inclusion, the sense of cultural humility, and also preconceived generalizations. Like, the students learn quickly what we see on the news is not always what happens in real life. So how to look for truths within our knowledge that we receive. Ethics and health policy. Many were shocked at some of the experiences they had at the ICE detention center, crossing the border, things like that. And then, of course, the social determinants of health, inadequacy to healthcare, poverty, safety concerns, the list goes on and on. So we wanted to just share this with you, that, consider a service learning trip, adding an academic component to that, and as a way to accomplish some of the components that we're trying to, as we have spoken earlier, to develop well-rounded clinicians that can serve a variety of populations. And that's it. So thank you for the opportunity to share.
Thank you very much, Dr. Jones, for sharing with us an innovative approach to service learning for students, and then being able to align that experience with the core essentials of nursing education. And I'm sure we'll have a lot of questions and inquiries about that. Our next presenter is going to be Dr. Kelly Bryant, who will speak to us about one approach that she has designed for creating pathways for historically marginalized students to become health professionals. Dr. Bryant, you're with us, ready to take it away?
Thank you. And hopefully you can see my screen. So good afternoon, everyone. It's a pleasure to be here today. And let me get started since we only have 5 minutes. So to tell you a little bit about the work that me and my colleague, Dr. Lee, who couldn't be with us today, we created a health professions pathway program for high school students. And I don't know if I need to tell you the reason why. When we look at health equity, we know one of the biggest ways that we can advance health equity is by having a diverse healthcare workforce. So we have the Institute of Medicine that's stated that. We also know when it comes to having diversity within the healthcare system, that improves patient outcomes, patient-provider relationships. And in addition, we need to make sure that we're preparing individuals for the diverse population that they're going to be caring for, as the United States is becoming increasingly diverse. So when we look at the current status of the United States and our nursing workforce, we know that in the United States, about 38% is from minoritized racial groups, but yet only 19.2% of the nursing workforce is diverse. So what are we doing about it? What are ways that we can increase the diversity? And when we look at particular ethnic populations, the Black and Latino or Hispanic is the fastest growing racial ethnic groups in the United States, but the most underrepresented when it comes to the field of nursing. So we need to have more of these pathway programs to encourage people from underrepresented backgrounds to consider a career in the health professions. I'm biased, obviously. I would love to have more people into the nursing workforce, but we also need that in medicine, occupational therapy, physical therapy, dentistry, all of those fields also have a very limited amount of underrepresented students entering those professions. So some of the advantages of the pathway programs that a lot of the programs include academic preparations through additional classes, tutoring, particularly in the STEM sciences, experiential learning opportunities, such as having opportunities to either go into the hospital and have clinical experiences or wonderful experiences in our simulation centers. Mentorship, which is so important, clinical experiences, maybe experiences with research and other critical structural support systems, such as conversations about what does it take to get into these programs, talking about the exams that are needed, costs, how do we get scholarships, how do we cover the entering these programs financially. All of these topics are included in a lot of these pathway programs, and including ours. And so what we had for our particular program, it was a 6-week program. It was 1 day a week on Mondays from 9 to 1 p.m. We received a very generous grant from our vice provost. It was an anti-racism seed grant to start our program. So during those 6 weeks, the first week we had a Health Professions Career Expo. So we had representation from many different fields. We had OT, PT, dentistry, medicine, nursing, genetics, nutrition, I think social work. They all came and presented on their field, and students had an opportunity to ask questions. And also, if students were interested, they can contact these speakers, and they provided some mentorship for these students. The second week, we had all the students go through CPR training. They actually received their American Heart Association CPR certificate, which was great to put on their resumes. The third week, we had a entire presentation, a day dedicated to teaching them about health equity, talking about health disparities, particularly around cardiovascular disease and maternal health. And that was in preparation for them to work on their assignment, which was due that last week, which is to create a PSA addressing a social, a disease that affects predominantly communities of color. For week 4, that was a day in the life of the nurse. So this is where they had a very interactive day in our simulation center, where we taught them skills during the morning, and then we put them through a simulation where they actually had to take care of a pediatric patient having an asthma attack. So we taught them how to listen to lung sounds, how to interpret vital signs, how to administer a nebulizer. So they took all those skills that they learned in the morning, and then they incorporated that into a simulation so that they can truly understand what is it like to be a nurse, not what you see on television, but actually to learn about nursing and then to play the role of a nurse in the simulation. And then the following week, they had that kind of a similar opportunity in the simulation center that was located in the anesthesia department. So my colleague on this grant was an anesthesiologist, so they went with her to her simulation center, and they did everything from suturing to intubation to ultrasound, and learned more about the life of an anesthesiologist. And then that last week is when they presented their presentations. They were in 6 different groups with different topics, from addressing opioid epidemic to maternal health. And they had, again, 1 minute to present a PSA addressing what is the concern and what are some suggestions on how we can combat that particular health condition. And then, of course, that last class, we had a celebration, we took pictures, and we put them through a very fun escape room where they ran all over the simulation center. And each clue was based on something they had learned. So there was a station that was about, there's an epidemic. What are the steps to dealing with the epidemic? What are the social determinants of health? In this room, they had to, one of the rooms, look at the room setting and pick out all those dangerous hazards that they saw in the room. So it was just a combination of skills and content that they learned throughout those 5 weeks, and kind of put that into this fun interactive escape room where they had to go puzzle by puzzle and solve it. And whoever solved it first was a winner, and we gave them a prize. So we tried to make that last day fun and interactive for them. So at the end, we did do a survey, and we wanted to learn. It was our first time doing this. And although it was modeled from a particular Robert Wood Johnson summer health professions education program that I've had the opportunity to participate in over the past, I would say, 7 years, we wanted to know what worked, what didn't work, what did they find helpful, what suggestions do they have if we were to repeat this another year. So the interactive sessions such as the CPR and of course the day in the life of the nurse anesthesiologist were rated the highest because these group of individuals love hands-on, they love to be in the simulation center. And of course the lectures were less popular than the interactive sessions. CPR, as I said, was definitely one of the highlights. The escape room they loved. And that taught them to work on not only just fun, but they had to work together as a team, communicate, problem solve, and use those skills they had learned. So that was definitely a highlight. They did suggest that we have more opportunities for research. We need to do a better job with pairing students with mentors. It was kind of done kind of loosely. So having a more structured approach to pairing them with mentors. And then we also wanted to be able to follow them long term. We wanted to see how many students that originally came into the program thinking they wanted to go into nursing or medicine or social work. By having this opportunity, did it change their minds and have them reconsider different professions? We wanted to follow them and say, did this program really help? A year from now, are they still thinking about the health profession? How close are they to entering a health profession program? Did they get in? So we want to have a more robust follow-up system. And also, which is very difficult, the students wanted opportunities to shadow in the hospital setting. But as you know, it's very hard, so many clearances and red tape to get students actually in the patient care setting. So we weren't able to provide them with that, but looking towards the future, having that in place. So those were the results of our 6-week pathway program. Here is just my contact information in case there's any additional questions. Thank you. And thank you, Dr. DeWitty, for allowing me this opportunity to write this article.
Thank you so very much, Dr. Bryant, for sharing with us a very innovative process for a pathway program. And I'm sure that many in our audience and others who read your article will be contacting you in hopes of replicating the model that you've developed. And now we are going to move to our to Lucretia Bell, who is going to present a media review on the book, The Sum of Us, What Racism Costs Everyone and How We Can Prosper Together.
Hello, everyone. Good afternoon. I want to make sure I get to the slideshow. And let's see here. Good afternoon. Thank you so much to the editorial team for this opportunity. Thank you to other authors that are here, laborers, and definitely our ancestors that make this work possible. My name is Lucretia Bell, and I'm a clinical faculty member at the Duke University School of Nursing. I've had the wonderful opportunity of reading and rereading Heather McGhee's book entitled The Sum of Us, What Racism Costs Everyone and How We Can Prosper Together. I just wanted to make sure we saw this beautiful author. This is a picture of her, not a picture of me, but she is here and she has done a tremendous work, and her writing definitely contributes to every sector of society. So a little bit of a background about Dr. McGhee, Dr. McGhee's. It's important to me to really be able to share people in their life experience and how that life experience shows up in their writing. So Dr. McGhee, her early childhood began in the South Side of Chicago. So this is a metropolitan area. The South Side of Chicago is unique in that it has wards, and it has a very rich African-American history, historically so, currently, but also has had a lot of political unrest. And a lot of the writings and the research that Dr. McGhee has done really is about this social political perspective and how racial inequity intersects there. So in her book, surprisingly, in the introduction, the first line of the book reads, "Why can't we have nice things?" And so this is a reflection of her childhood and sort of her investigation and inquiry as to what she's seeing and why it exists. So she goes to her mother and describes what she's seeing, and what she sees is this disrepair of neighborhoods, this preponderance of industry layoff, this racial homogeneity, which we still see in education, that aligned with lack of resources and opportunities. So she was seeing these things, she began to write about it, and this sort of initial perspective was her foray into understanding the social economic inequities. So as she moves on, she moves into higher education. She attended Yale University for her undergraduate education and UC Berkeley School of Law, where she received a doctorate of jurisprudence. She became an attorney in 2009. Following that, she began to work for an organization entitled Demos. So this is an organization that focuses on policy research. And really the crux of the organization is to help make sure that thought leaders and legislation is put forward that can really kind of round out and understand this idea of the invincibility of our nation. So really a proponent of democracy and making sure that there is equity and all voices are represented by the candidates that they're moving forward. So that's the organization that she worked for. And during that work, she was able to engage with lots of political candidates. She was able to complete interviews, and I'll talk a little bit in the next slide about how that shows up in her book. But through this work, she identified this pervasive social economic inequity that she has represented in her book entitled The Zero-Sum Paradigm. So in that zero-sum paradigm, we think about it in terms of, for example, the cost of housing. So the cost of housing determines who lives where, which then determines where you go to school, which then determines who you see and what you learn when you go to school. That then determines what resources exist or are offered. And all of those things really do impact learners, they impact nurses, they impact how nurses are able to enter into education and the challenges that may exist in front of them. So to sum it up, because my 5 minutes is approaching, this text to some of us is a compelling read. The zero-sum paradigm that Dr. McGee describes, I'm sorry, oops, too soon, that she describes is a lie. So the zero-sum paradigm is a reflection of the notion that if someone wins, someone has to lose. So if there are marginalized people receive what they need, that it will dismantle the very sturdy structures that have benefited the majoritized folks. And so that is not true. What she describes in her book is 104 pages of receipts that is following the text, that is following this step-by-step process of socioeconomic inequities, of environmental inequities, of educational inequities, and she has receipts. Those 104 pages are chronicles of her historical accounts, of her interviews, of everything that she's culminated to be able to make sure that people understand this very important work that she's done. So racial equity is the precursor to healthcare equity. As all of the authors have talked about, when we have racial equity in terms of who is showing up in the classroom, who is showing up in the research field, who is showing up in the clinical environment, that allows us to have healthcare equity. Students can see themselves in people that are diverse. They can see themselves in experiences that are diverse. So she moves on at the end of her book, and she describes the solidarity dividend. And the solidarity dividend is sort of this participation award. We have gotten away from it, and we don't want everyone to have a participation award, but it is just that with racial equity, that everyone wins when we do the work for everyone to win. So when we provide opportunities for those that need those opportunities, the majoritized always win. So whether that's in housing, whether that's in school, whether that's in education, we need to make sure that folks that have the needs are there at the table, are represented, and their voices are heard. So she describes this work of us being able to be superheroes. So racial inequity does not have to be our dividing power. We can have solidarity as our superhero power. Thank you for this share.
Thank you so very much for informing us about what an exceptional read. And I think now we all want to put it on our Christmas wish list as a gift. I think it's terrific. And I'm sure that there are going to be some other questions. The use of the term solidarity dividend is really kind of, piqued my interest an awful lot. And so thank you for that review. And now we're going to move to our next presentation, which is on belonging. And earlier on, Marty talked about belonging being the other extreme of marginalization. So now my dear friend and colleague, Bridget, is going to talk with us about her manuscript on belonging.
Thank you so much, Dr. DeWitty. Our title is Overcoming Marginalization by Creating a Sense of Belonging. And this was a creative effort by myself, Dr. Danica Sumter and Dr. Wanda Thurston. So really, we just wanted to spend some time in this article advocating for helping people to understand that we believe the solution to marginalization really is around creating that sense of belonging. In the sense of belonging, I'm just going to give you how we define it, was a sense of belonging is a subjective feeling of security and support that allows a person to bring their true, authentic self and feel welcomed and celebrated so they can thrive, contribute, and also see themselves reflected in the culture. And we created that definition with the support of racial equity tools, as well as some other literature. But what I find is most important for all of us is to create these definitions so our organizations have these definitions to do their work from. We know belonging is fundamental. It's critical for our mental well-being. People saw that during the pandemic. Loneliness was a big topic during the pandemic. And so when we think about our well-being, our success, whether that's academically or as staff or faculty, and even our personal and professional growth is critical. It's really important for us to understand how it impacts us. It impacts how we engage with one another, the retention in terms of whether it's our hiring or our student retention and faculty retention, and even just our overall personal and professional development. So we do know, this is well documented, that when people feel that they belong, they are more likely to do things that would actually support their engagement in the organization. So we know that, however, achieving the sense of belonging is not exactly straightforward. There's a lot of challenges, and we really have to look at both the individual and the institutional levels. So we really, I'm just going to be talking a little bit about some of the things that we can do as an individual for individuals, which are things like creating gender neutral bathrooms, having prayer and meditation rooms, designing, and we just talked about that, orientation programs that actually acclimate not only students, but our staff and faculty to their roles. When we think about our training, we need to do training that makes sense for how we want to support this sense of belonging in our organization. So oftentimes we just throw trainings at people, and we really need to make sure that it's meaningful and that it's actually scaffolding to help in the personal and professional development of our community members. And when we think about our organizations, the biggest thing for me is that we really need to make sure that we are showing this in our core values, that we're showing this core values that are threaded throughout our strategic plans. Because if it's not part of who we are and what we're doing to develop our community, it's not going to show up. And we really have a responsibility. We have to educate, we have to raise awareness, we have to provide training for all of the people within our organization so that they know how to recognize, mitigate bias, and mitigate discrimination. To me, that's part of making sure that our environments are supportive. So the last thing is the inclusive policies. How many of us have gone through all of our policies in our organizations to make sure that they support inclusivity and create that sense of belonging? And I think that's really important for us to do. So in the long run, the whole thing, I'm going to make you read my article, so I'm not going to give you all my tidbits. But really the main message here is, if we want to combat marginalization, we have to be so intentional in our efforts to create these inclusive environments. That's the thing we have to do. So thank you.
Okay, Dr. Carter, thank you for that. And now everyone's got to read your article so they can follow up on those wonderful recommendations that you've offered. Our next presenter is going to Dr. Isabel Francis will discuss the invisible minority. Dr. Francis, are you there?
Hi, yes, thank you. And I am not Dr. Francis yet. I'm a PhD student and a graduate research associate at USF. So thank you for that. But I cannot claim that title at present. And I'm so pleased to be able to speak with you today about stigma, sexual and gender diversity, and the healthcare system. And this particular group of marginalized individuals has been called the invisible minority because sexual and gender diversity is not necessarily something that is visible. And this kind of an umbrella term, sexual and gender diverse, is an umbrella term for the commonly known term LGBTQI+. And it includes two different but related populations, people whose sexual orientation is different than that of heterosexual, and so it's non-conforming, and people whose gender identity, their own self, a sense of where they fall on the spectrum of male to female, is not necessarily conformant to the majority dominant culture. So sexual orientation, gender identity, they're different, but they're related concepts, if you will, under this big umbrella of sexual and gender diversity. And Marty was kind enough to read my definition of stigma in this particular regard, which is a form of social rejection of this population resulting from an imbalance of power, which, as we know, the normed dominant culture marginalizes this population, but also there's an imbalance of power within the relationship generally between healthcare provider and patient, a lack of knowledge. And this comes from our lack of recognition for decades, millennia, that there is absolutely a genetic component to sexual orientation and gender identity. And this process results in labeling, stereotyping, and discrimination, which excludes an individual or group of individuals from normed privileges. And what these privileges are is a sense of a right to care or a presumption of medical care. Myself, I am a white cisgender heterosexual woman. So when I go to the doctor or I go to any healthcare facility, I figure, well, yeah, they're going to take care of me, but not so necessarily for this population due to this idea of stigma. So what kind of goes into stigma? Well, there are any number of components, and they range from, if you're familiar with my minority stress model, those which are distal and those which are proximal, or those which have really nothing to do with the individual, and those which are very personal. So at the top left, we see here structural discrimination, and that would include discriminatory laws and policies. As you may know, the Affordable Care Act did include a provision protecting sexual and gender diverse minorities from discrimination within healthcare settings. That provision was removed in 2020, and all efforts to reinstate it have been blocked at the federal level. So that is, the farthest from what the individual is in any control of. Then the expectation of discrimination or past experiences of discrimination among this population contribute to their healthcare utilization experience. Identity concealment, not necessarily wishing to disclose one's sexual orientation or gender identity, contributes. And also this idea of self-stigma, which is a negative attitude or an internalization of some sense of shame regarding one's sexual orientation or gender identity. So all of this kind of goes into the decision for this marginalized population of whether or not they're going to utilize the healthcare system. So you can see on the right-hand side of the model, frequently they decide no because of all of these factors. They avoid primary care, and we were talking a little bit about the costs of marginalization. This means that they don't get their cancer screenings. And in fact, there is a disproportionate burden of cancer, various cancers, in the population of sexual and gender diverse persons. That's a very real and obvious cost. But what if people from this population do decide to utilize the healthcare system, on the left-hand side of the model, we can see one thing that is an actual modifiable factor. And that is the provider experience, the patient-provider experience. So if providers don't feel comfortable with this population, or they don't have the knowledge of their very unique needs, then the patient can once again experience or perceive that they're experiencing discrimination, that reinforcing their decision to avoid the healthcare system. But the good news is on the very left-hand side, that patients who have experience with providers who are comfortable and knowledgeable with them then have increased resiliency, self-efficacy, and enhanced well-being, which reinforces their decision to utilize the healthcare system again. And nurses are particularly well suited to participate in this reinforcing loop, because qualitative research has indicated that sexual and gender diverse persons who see nurse practitioners as opposed to other types of primary care providers feel that the interactions they have are more successful, that the nurse practitioner is able to spend more time with them, and they have actually voiced a greater willingness to participate in primary care screenings such as cancer screening. So I know that I'm in 5 minutes. I know that the IOM and National Academies call for nurses to be at the forefront of leading health equity, and yet we are very rarely given the power to do so. So this is one aspect that we can include more curricular information about caring for sexual and gender diverse populations, and we can truly bring that throughout academia into every aspect of curriculum, baccalaureate through graduate. And the reason this is absolutely timely is that the number of persons identifying as sexual and gender diverse has increased to 20% in Generation Z, greater than 20%. And these young people are aging into, 2/3 of them are going to be aging into cancer screening guidelines soon. So it's absolutely imperative that we as nurses have the ability to feel comfortable and competent in caring for this population. And thank you very much for letting me speak to you in this regard. And I want to just encourage everybody to take their power.
Thank you so very much, Isabel, for that outstanding presentation and bringing once again to the forefront the need for us to expand our knowledge and experience in providing care for this population of patients. And so now one of our authors who was not here earlier, we're going to go back and invite her to share her presentation on the collaboration and sustainability of HBCU partnerships. Dr. McEwen, are you there?
I am. Thank you so much. And I so apologize for earlier, and I appreciate your graciousness in letting me join you late. I am very excited to talk about the collaboration that I had with several of my colleagues at Walden University. We were inspired by a health equity summit that was hosted by Adtalem Global Education in 2022 that focused on many issues in health equity. We are educators, and we take the findings of the Spelman Commission, for example, very seriously. And this article, I'm just going to be honest with you, it's very ambitious. We have a lot of heavy hitters who contributed to the article. I think of people like Catherine Holton and Sri Banerjee and Phyllis Morgan and Amber Cook and Jeannie Thomas and Alisa Vizi, who all are very, very strong in their particular practice specialties. And this is a diversified group. And we were thinking about how the call to diversify nursing in general is, the formal call is well over 20 years. And so if we think about the cost of marginalization, one of the areas that it's expressed and perhaps very difficult to measure is in the, or are in those educational opportunities for minoritized communities. And one of the hopes of suggesting sustainable partnerships with HBCUs is to increase the number of people from marginalized communities that represent not only nursing, but healthcare professions writ large. It's an ambitious article, like I said, and we discuss the social determinants of health as a curricular innovation across multiple disciplines. And we focus on nursing and public health, social work, all of the areas that we know that the social determinants of health can afford a very strong lens and can engage a number of different research initiatives and understandings across and within multiple disciplines. Something that we're really interested in, though, is the idea of promoting faculty development in interprofessional education and designing interprofessional education opportunities across multiple universities. I think this is not necessarily a completely novel idea, but the idea is to branch out and partner with historically Black colleges and universities who have historically been underfunded, re-marginalized, and I'm just going to also say re-traumatized by that aspect of being effectively left out of many larger national conversations because of a lack of funding, a lack of resources. And if there are opportunities to create interprofessional educational collaborations in and among a variety of institutions, I think the potential for inviting more types of students to the table is real. And I think like the previous presenter, I'm going to leave much of the questions of how do we see this happening to please read our article and please engage with us and let us know your thoughts. It's an exciting time to think about social determinants of health in a broader context, especially since the NLN and other major nursing organizations are kind of re-inculcating, if you will, social determinants of health within nursing curriculum. And I think what we're hoping to do is just inspire multidisciplinary interaction and cross-institutional action for students and for faculty. So thank you once again. I really appreciate the opportunity of joining you today.
Thank you so very much for your participation and for sharing your manuscript with us. There was one author who that we had expected but did not make it here. And so I'm going to ask Marty if she would take just a few minutes and give us a high-level overview of the article that was written by Susan Hewen, and it was on using simulation to address structural racism in healthcare.
I'm very glad to present this article, and I just looked again, and I think she isn't able to attend today. So, but our journal, she's been a colleague of our journal for quite a while. Dr. Hewen is a professor of nursing at St. Olaf College, which is a small liberal arts college. It's about 30 miles south of where I am right now. And they have a very strong baccalaureate nursing program for many, many years. That college has traditionally been not a very diverse student body. It's becoming more diverse, but they've also been at the forefront of social justice issues for a long time. And I'm seeing two new messages here, but neither of them is from her, it looks like. So I'm going to go ahead and tell you about this article because Dr. Hewen and her colleague, Professor Mary Beth Kuhn, have contributed several articles to our journal, and they did a two-article series about a poverty simulation that they did. So since their student body is mostly majority students, they are very conscious of needing to broaden their students' scope and confront their own biases, both conscious and unconscious. So this article is about an exercise that they did. It's a simulation in which the students were confronted with behavior by a fellow healthcare professional that is just so wrong on so many levels. So in preparation for this simulation event, they studied two different things. They studied social determinants of health, and they studied the opioid epidemic. And so when these students came to this simulation event, they didn't really know what the details were going to be. And it turned out to be, the scenario was that there is a patient, a postpartum patient, which was represented as a mannequin. It wasn't a physical live actor in the bed. And this simulated patient was a nursing student of color who is 1 year sober from opioid addiction, on maintenance Suboxone, and doing well in nursing school. This simulated patient had a baby the night before that was a little bit early, and this patient's partner is out of state working, so isn't there right now. So these students meet this simulated patient, and the patient is reporting significant abdominal pain. So the students call the provider, and the identity, you don't know whether this provider is a physician or a nurse practitioner, male or female or any other gender, and what racial minority this provider is. All they knew is that it's a provider's voice on the phone. And the provider refuses to come to the bedside and refuses to order any analgesia, and says she's one of those people, she's a junkie, and she's just wanting more drugs. She's just drug seeking. And the students in the simulation they do whatever it is that they think they should do. That aspect of what they did in those next few seconds isn't really addressed in the article that much, because the point of it is what was the experience of these two students and then the other people who were observing. And the effect, many of these students, in fact, their responses are categorized under 3 themes: shock and anger, need for advocacy, and glad for preparation. So the first thing was they couldn't believe what they were seeing and hearing, which indicates that they maybe have led kind of sheltered lives so far. The next was that they were so aware that they needed to do something. What they would do, how prepared they felt to do anything varied, but they knew that they needed to do something, that the buck stopped with them to do something, and that they were glad for the chance for this exposure to see what their future lives as healthcare professionals might actually be like. So what Dr. Hune says is just, to me, is so touching. Creating organizations in which everyone has access to the opportunities they need to thrive depends on our willingness to confront the history and impacts of structural racism in the healthcare system, and to take action to interrupt inequitable practices at the interpersonal, institutional, and structural levels. So this simulation on the topic of implicit bias and racism provided an opportunity to open and deepen important conversations about equity, belonging, and justice. And one other point that Dr. Hune makes is research on health disparities has historically been limited by focusing on the health problems faced by people of color while neglecting the perpetrators of racist practices and institutions that have created these problems. So I encourage you to read this article for the details on how these students' responses were interpreted.
Well, thank you so very much, Marty, for providing that overview of the article. And wow is all I can say. What an outstanding addition of creative nursing Redesigning Healthcare and Understanding the Human and Financial Cost of Marginalization. So I want to thank all of the authors who have contributed manuscripts to this outstanding issue of creative nursing, and it will be available really soon. I think the authors received confirmation of their print earlier today. And so now what we're going to do is open it up for conversation and discussion. I'm going to ask Jasmine if she can bring us to gallery view so that we can have some conversations, if we might. Okay. So are there any questions that we have from any of our authors, or any questions to the authors? Just feel free to unmute yourself and speak up. And
Bernal, do you want people to use the raised hands, or should they just talk? What would you
well,
prefer?
I think you can raise your hand and then unmute yourself and ask the question. I think that would be great. One of the questions that I'll ask to just kind of get us started is, Dr. Jones, you spoke to truth and reality when the students were having the experience of becoming more aware of what life was really like on the margins. And many of the manuscripts spoke to that. Can you tell us a little bit more in terms of how faculty members might be able to awaken in their students what this truth and reality really is, in such a way that they really do understand what marginalization looks like?
Bernal, before we go any further, I'd like to call out that we do have one more presenter here now. Brittany Woods is here to present the article about the African American lived experience with cystic fibrosis. And
okay, all right. Well, thank you so much, Marty, for pointing that out. I didn't have that on the script. I don't know. So, are you here and ready to speak to the African American experience with cystic fibrosis?
Yes, I am.
Okay, go right ahead. Yes.
Fine. Go ahead and okay. So thank you guys. So this is the lived experiences of African American individuals with cystic fibrosis, and I apologize, I'll speak very quickly. There's quite a bit of stuff to go through.
Brittany, you have 5 minutes just like everybody else.
So for those who are not aware, cystic fibrosis is a pretty rare disease. It affects about 30,000 people in the US. It's mainly characterized by like this excess mucus production from a gene mutation, and it will affect the lungs, the reproductive system, the digestive system, but it's historically kind of known as a Caucasian or white disease. So African Americans only make up about 5% of the individuals that experience this disease. So it really makes them kind of this whole another level of rare within a world of rare disease. And African American or Black individuals with CF are more likely to report poorer outcomes, like using Medicaid. They're underrepresented in cystic fibrosis drug trials. They report poorer social and emotional outcomes and lower quality of life. So it's really critical that we as healthcare workers make sure that we are meeting their needs and hopefully improve outcomes. So that was kind of the purpose of this study, was really to investigate their lived experiences to identify if there are any potential health disparities that they're experiencing, particularly with access to treatment and to healthcare. So to do this, we used a phenomenological study, and we interviewed 12 African-American persons with cystic fibrosis, and we audio recorded everything and then transcribed them verbatim and analyzed them using phenomenology. And so we came up with 3 big themes: were accepting this diagnosis of cystic fibrosis. So This was kind of a different experience from a lot of their white counterparts with cystic fibrosis, is that years past, this wasn't as well known that African American and Black individuals can get cystic fibrosis. This was not something that was as well known within, especially smaller healthcare facilities. So several of them experienced really difficult times actually even getting a diagnosis. They really had to advocate for themselves to be able to get this kind of diagnosis. And it definitely was a shock for a lot of them. But what we found was that a lot of them described this taking a toll on their mental health. They really felt like a burden on their family because it's a very high treatment burden with constantly doing these medications and breathing treatments and everything. It was really a lot of them even talked about being suicidal in their younger days because they felt like they were just a burden on their family. And then obviously, you know, they wanted a normal life because, as I kind of talked about, there's this whole nother level of living with an invisible disease when you're a minority within a minority. And I think, you know, we kind of discussed some of that earlier. So they really felt like they were invisible within this invisible disease. You know, they wanted that normal childhood where they participated in, you know, what they considered normal activities just like everyone else, but you know, they were taking medications every meal, they were doing breathing treatments, so they were really limited in their activities as children. But also CF really permeated all of their life decisions, not just you know, their healthcare decisions, but really their relationships. They had to have somebody who was going to be okay with the fact that CF was a huge part of their life. They were going to have multiple hospitalizations every year. They're going to have shorter lifespans. You know, luckily some of that has changed a little bit. We have definitely increased the lifespan, but it's still, you're going to have shorter lifespans. You're going to have a lot of health issues. Even going to school, you have to think about, where is a treatment center in relation to where you're going to go to school? What kind of job are you going to have? So all of this really permeated all of their life decisions, really kind of keeping them from having this normal life that they wanted. And when we asked about, we were primarily concerned with how was the CF care team that most of these patients consider to be their kind of de facto primary care team, how were they addressing, you know, their healthcare? Was there any racism or cultural sensitivity, insensitivity, anything like that within that? We were pleasantly surprised that everybody said they felt like they were doing an amazing job, but they were experiencing these subtle racisms with outside of their care team from other healthcare workers, from their professors. One of them actually talked about that there were teachers, one person had a professor want to watch this person go to the bathroom because they didn't believe that they were, that they had this disease. They thought they were cheating. So they actually wanted to see them go to the restroom. So, I mean, these are things that you would not experience as a normal person. You know, so there's definitely a lot of areas for improvement. And the other thing was that they didn't see themselves within, they didn't have any representation. So that was a big thing. You know, I think we've talked a lot about that, having representation within the healthcare system, within, you know, seeing yourself within your healthcare workers, whether that's nurses, physicians, but really just having that representation that they could grow up. They didn't know any other African American or Black individuals that had cystic fibrosis, so they didn't think that there was a chance for them to be able to grow up. So overall, you know, we've talked about this, you know, we need to increase representation. We need to improve provider diversity. I think we're getting there, but we still have a long way to go. We're definitely making those pushes to do that, but there's a long way for us to go. Encouraging responsible involvement in research, connecting them with peers who share their cultural and religious values so that they have that more sense of community. Obviously, some more cultural based training is needed for not only CF providers, but all healthcare workers in any institutions, you know, schools, everything. And really making sure we're looking at more goal concordant care, meaning that, you know, we're using those effective communication strategies to really incorporate patient beliefs, values, family support system, treating them as a whole person. So, you know, yes, they were met with a lot of the same challenges that were experienced by their white counterparts with cystic fibrosis, but they still face several systemic barriers to care, from implicit biases, structural racism, sociodemographic factors, and really it all goes back to a lot of the uncertainties in their rare disease process when it comes to like the inequities within treatment with drug treatments for cystic fibrosis. So even within that rare world of CF, there's really a whole nother level of stigmatism that they're having to deal with. So that's pretty much all I have. I just wanted to say thank you to everyone, to Creative Nursing, for allowing us to share this work, to our authors that you can see down here. And then of course our study participants in the CF community and our funders at the CF Research Center. So thank you.
Yeah.
Well, and I'd like to jump in just before we get back to Brunel's question from before. This article, what it hit me upside the head. If you are a healthcare provider and you are looking at a person in front of you who is African American, and they are describing symptoms that would maybe indicate that they have cystic fibrosis, if that isn't on your radar because you think that African American people don't get cystic fibrosis, that's, I mean, in a way, you're showing your ignorance, but maybe it's a little more understandable. But to say to this person, you are lying, I just have to put it out there. And I can see a comparable thing if someone is in front of you who does not look African American and is describing symptoms that might indicate sickle cell anemia. Not everyone who is in front of you looking like they aren't African American is not genetically having sickle cell anemia. So to me, the takeaway of this whole thing is not don't believe your eyes, but open your mind. Yeah. That's all I got.
Yeah, it's very it's a very salient point, and as we approach all of those who seek care from us, having the compassion and having that curiosity and being willing and open to learn more about who the patients are. So thank you so much for bringing that to us, and very, very unique perspective. I would like to now take us back to that gallery view and see if we have any comments or questions from anyone. Dr. Jones, I think I had asked you to add a couple of comments, because I think the whole notion of truth and reality is something that can be applied across so many of the manuscripts that have been described today.
Yes, thank you. I'll do my best here. I think it's important for us as academicians to make sure we are being involved in our community and going and finding out for ourselves the situations around us. You know, I've been blessed to work at Baylor, and blessed to work at Baylor, where we go on mission trips and are able to take students to experience that. But I think if that is not an option, I think knowing who your experts are and being willing to maybe have a panel where you can reach out to you know, for example, people who've crossed the border, like, why are they coming? I know the first time I went to the Rio Grande Valley, I was scared because it had just, the way it had been described to me, I thought it was going to just be drug runners and you were going to be, you know, in danger at all times. And when I got there, I was like, this is no different than downtown Dallas. You have to be aware of everything around you. It's no different than anywhere, you know, people live here. So it has to be relatively safe. So I think just seeing, and when you hear the stories of people who have actually come across the border, why they've come, you know, it's not the drug runners, it's not, they're fearing for their lives. And many of them have left their families behind. So I think learning to share those real experiences with your students, be real in that, be real in your experiences, reach out to those who know the communities, have students engage in activities if possible. I know I'm in the online environment, so it's limiting sometimes, but have them engage in activities where they go to the marginalized areas of where they live and see how people live and what they experience. And that was a real eye-opening for our students to see what they had actually been missing, even providing care in the Valley. So I hope that answered.
Yeah, thank you so much. And Isabel Francis has her hand up.
Yeah, I just want to add a little bit to that. The the outreach to the community is absolutely critical. As I was doing my research, I thought, well, I really need to get to know members of the SGD or the LGBTQI community in Tampa because I'm not from Tampa. And via Facebook, I connected with a person who was a founder of an LGBTQ serving organization. Long story short, he identifies as he, him. We had a great discussion, brought this idea to our diversity committee for our College of Nursing. How about if we do an LGBTQ health fair in the Tampa Bay area? And this just snowballed and mushroomed. I'm sorry, somebody else was speaking about using their mobile health van. And so that is going to happen. The USF mobile health van is going to take USF undergrads to participate in the health fair. Tampa General Hospital was kind enough to say they would participate, Planned Parenthood and any number of other LGBTQ serving healthcare organizations. So the idea that you can reach out to communities where you are and create these novel experiences, both for undergraduate and graduate students, is really powerful. And that's the best way, I think, of connecting students with the people they'll ultimately be serving.
Yeah, that's really great. And Lucretia Bell, I'm going to ask you to explain just a little bit on that concept that really grabbed my attention, the solidarity dividend, because I think at the end of the day, I think the 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 knowledge in terms of the sum of us, in terms of because I think there is perhaps a misperception that if you help others, then you have less. So talk a little bit about that because I think that's one of the things that may be one of the barriers in terms of our being able to really advocate for greater equity in all that we do. So speak to that just a little bit more.
Yes, thank you so much, Dr. DeWitty, for asking me to share a little bit more about this. So Dr. McGee and her work really does, like I previously stated, does a lot of research in this social economics area. And in her discovery of lots of the inequities, a lot of her focus was around legislation and political kind of candidates and moving them forward. So this idea of the solidarity dividend is sort of the antithetical perspective of the zero sum. So the zero sum, like I've stated, is this idea that if we provide equity in housing for marginalized folks, then someone is going to be left out. Then I might not be able to uphold the sturdy, ubiquitous structures that actually allowed me to have privilege. So I think the things that are important in the solidarity dividend, especially as we're talking about healthcare, is really, first of all, for me, I think thinking about your location. It's really important for me to identify my location, how I show up as an African-American cisgender woman. So that has some privileges in some areas and some marginalization than others. So I think all of us have sort of this work to think about our location and how we show up. We also have this commitment, a shared commitment to health equity and understanding that if it benefits someone else that may be marginalized or minoritized, it benefits me too, and it benefits humanity, especially in the space when we're thinking about the disparities of educators of color, when we're thinking about the disparities of educators with diverse backgrounds, and we're thinking about the number of students and what students are actually coming into nursing. So thinking way back to the social and economic perspective, it's important that we advocate for the solidarity and legislation when it comes to legislation that provides equity, legislation that provides equity in all the spaces, whether it's an environmental space for climate control, whether it is an educational space, whether it's in healthcare space. That all helps to move forward the agenda of equity for all, racial equity, ethnic equity, diversity equity, and then we can move forward into the healthcare sphere. So this solidarity dividend is really this idea of this sort of the participation award that we all win when we all participate. I think the participation award has had a negative nomenclature, but we do all win. We do all win, especially in this work for racial equity.
Thank you so very much for expounding on that. And I think, when we think about marginalization and we want to envision what are some of the approaches, what are some of the strategies, and what can we do to address that, I think that was really, really very eye-opening. Are there any other questions or comments from anyone for any of the authors? I can keep asking questions until 3 o'clock, but I want to give someone else an opportunity. Well, any other questions? So Dr. Bryant, I'm going to ask you, I'm going to put you here on the spot. You indicated that you were able to get a grant from your provost to support your pathway program. And I know that oftentimes nursing faculty are challenged in acquiring the resources to do some of that work. Can you share with us how it is that you were successful in doing that, so that maybe we can learn a few tricks and approaches for anyone who might want to replicate that kind of a program at their school?
Sure. And I would say, to my surprise, you really don't need a lot of money or funds to run a pathway program. If you already have a center in place, you can use your own space. Yes, there's some expendables, disposables that you may have to purchase. But for us, it was an internal grant, and I want to say it was about $10,000, and we didn't even use all the money. And that's to cover, we covered their transportation, which is a subway pass. We covered their food each week. So we couldn't have this gourmet meal, but, we had Chipotle and sandwiches, and the students love pizza. So pizza's easy. And then we bought a couple of task trainers, particularly for like the intubation one. But again, you'd be surprised that on a low budget that you could still manage to have a very successful pathway program. It's really about getting individuals and getting people to participate. And you can use a lot of the existing equipment that you already have in your simulation centers. We did have to pay for, the CPR card, which again wasn't very expensive. We gave them a little swag bag. So we bought them a blood pressure cuff and a stethoscope and a little Columbia t-shirt and a book and a pen. Again, not a lot of money. Some of it came from Amazon. Yes, you can have a pathway program on a budget and it doesn't really, cost a lot of money.
And a follow-up question for you is, how did you recruit the students to participate?
So we have a collaboration with a wonderful program called Discovery Center that's been around, I guess, for over 50 years. So finding those programs in your area that already have in place connections with high schools, where they're going into those high schools to promote, programs that'll help students be successful into getting into college. So we connected with them. We had a flyer made. We even had a video made about the program. And then we distributed to some of our local high schools. We use social media. Obviously, social media is very big. So Columbia posted on social media. We had people that were well connected to the Department of Education who also spread the word for us. But I would say a lot of it was word of mouth, not as much contacting the schools, because we went through the guidance counselors, but I'll be honest, I don't know if it's in other areas, but in New York City, they are so overstretched. So we found it was hard to get them to distribute it, but with our other contacts and with social media, that was a big help.
Okay. Well, that's very good information for anyone who might want to replicate that particular program. Any thoughts or questions from anyone else? We're getting close to the hour, so I want to give everyone else an opportunity to ask a question, make a comment.
If I can just jump in for a moment and just express my appreciation and my love for all of you. I've been very deeply involved in all of these articles, which is one of the joys of being the editor. And I just was so moved by how this issue came together. When our editorial board brainstorms these themes, the theme of marginalization was chosen a year and a half ago. And that's what started in motion, putting this issue of the journal together. And some of the articles were solicited by Dr. DeWitty and Dr. Carter, and others just came in, as we say, over the transom, and they fit this topic so well. So I just say I love you all.
Well, thank you, Marty, so very much. And I also want to thank the Campaign for Action, the Center to Champion Nursing, for hosting this for us. And at the conclusion of this session, we will have a recording of this event, an annotated table of contents. You will be able to find it on the website of the Creative Nursing Journal, as well as their Facebook and their Twitter. You will also be able to find this on the website of the Campaign for Action. And Jasmine is going to put that web link into the chat for you. And as we close out, I want to once again thank all of the authors, especially the people who I called out and said, how about doing this? And thank you for being willing to do it and for showing up today to share this. And I want to wish you all a wonderful holiday season. And I don't know when, as our host for this event, do you have any closing comments?
Just a lot of gratitude. And Marty, I think you're so brave to say, I love you all. So, you know, love is something that we don't share a lot of, right? And I also share love and very deep gratitude with you, with everyone. And I'm really touched and was inspired by many of the sharings today. Jasmine?
Yeah, I just want to say thank you all so much. It was a pleasure to be able to host this and work with Marty and Bridget and Dr. DeWitty, of course. So thank you so much. And I look forward to also reading all of the articles as well. Thank you.
Absolutely. Thank you.